Wonderful to be able to see that type of sophisticated biliary surgery being done. That's what every one of our residents ought to be trained to do, I think, in the future. The next talk is given by a very special guest from France, Dr. Silvana Perretta, who is from Strasbourg, and part of that great AirCAD team. Not only are they doing innovative clinical procedures, but their innovative laboratory work as well, really a leader in the world. And Silvana is going to talk to us today about some innovative esophageal work that they're doing there as well. And I think she's using her own computer.
Yes.
While they're getting her ready, I will tell you that the last speaker of the day could not be here, Claudio Navarrete, and so you're going to have to put up with me giving a similar talk on the same subject. I've seen one case, so we're going to talk about it.
Thank you, Dr. Ponsky. Jeff, it's a pleasure to be here and to share with you our work on trans-esophageal surgery, which was a rather controversial issue at the beginning of notes and a clinical reality today. I have nothing to disclose but the fact that I was among the sinners who did dare to perform trans-esophageal surgery. I'd like to start my talk with this quote from Liz Runs from God put the esophagus into the chest to hide it from surgeons, but he didn't hide it from surgical endoscopists. And so we have today over 30 publications on both laboratory work and clinical work on trans-esophageal surgery, both on diagnostic procedures and interventional procedures within the esophageal wall and beyond the esophagus concerning mediastinoscopy, thoracoscopy, pericardial window creation and intracardiac injection, sympathectomy, lung biopsy, but also the hilar myotomy, which is going to be the focus of my talk today for the treatment of achalasia, which has been an operation that was a victim of several attempts to damage the hiatus and the esophagus itself. A variety of surgeries are rather scary to me. I don't know if you share the same opinion. Till 1914, when Heller performed a bilateral myotomy, 8 centimeters long, by thoracic approach. And the interesting thing is that already at that time he pointed out how important it was to go over onto the stomach side. Slightly modified in 1918, never changed for 90 years. So we've been performing for a very long time quite the same operation. We did move from the whalebone to the laparoscope, but we had to wait a long time to move from the laparoscope to the endoscope. And looking at the literature, I found very interesting to learn that in 1980, a guy from Venezuela, Dr. Ortega, performed 17 endoscopic myotomy on patients with apparently very good result. And he was very precise. He assessed all his patients with manometry, and he achieved a correct drop in lower esophageal sphincter pressure. In 2007, we have the first publication about the submucosal tunneling approach to the hilar myotomy from Promshrika at Stanford. In 2010, the so beautifully performed POEM procedure by Dr. Inoue. We took a slightly different approach at AirCAD in Strasbourg. We really wanted to know if and how the submucosal approach was effective in relieving the obstruction to flow. And we did that looking at two things. Manometry, of course, to observe the LES profile before and after the operation, but using also another emerging physiology tool, the endoflip, the functional lumen impedance probe, which gives you a very clear idea about the distensibility and the compliance of the gastroesophageal junction using impedance planimetry technology in a catheter. And we also compare our submucosal myotomy results to the standard surgical myotomy. At the beginning, we just aimed to reproduce exactly what we were used to do at laparoscopic surgery, so kept both the longitudinal and the circular wall of the esophagus with a long myotomy of about 8 centimeters. And this is how it looked like at the beginning. This, I think, is probably our very first animal. We incised just the mucosa 15 centimeters above the lower esophageal junction with a needle knife with a very low cautery setting. We used the needle knife. You can also use a balloon. We'd rather do our myotomy this way. It's less expensive. And we used the needle knife to dilate this tunnel and then to guide the endoscope into this submucosal space. and very gently, with CO2 insufflation set at a very low level, 8 millimeters of mercury, we just proceed towards the gastroesophageal junction with a very gentle blunt dissection, just following this plane, which is so nicely defined by the CO2 insufflation. Getting oriented is slightly different. Landmarks are not the one we are used to in laparoscopy, so it is very important to understand the endoscopic anatomy, to locate correctly the mucosa, the muscular layer, and the circular fibers. At the beginning, we weren't sure of where we were, so what we did, we added a laparoscopic view to make sure that we were going beyond the esophageal junction onto the gastric side. Again, full thickness myotomy, so we were cutting at the beginning both the longitudinal and circular layer. And we thought, well, normally in our clinical practice, we would add a partial funduplication to our myotomy. So we also explored the possibility of adding that at 4 weeks using an intraluminal funduplication technique by the esophageal device that I'm sure everybody is familiar with. And we achieved good results with no esophageal perforation. And this is going to be shown on the right side in a second. Hopefully. It's okay. So in terms of results, we had no intraoperative or postoperative complication, and I want to stress that we did this work in collaboration with the team of anesthesia, which were very precise and on controlling us, especially regarding ventilatory parameters of the pig. The ET2 level were stable throughout the procedure. We had no complication in terms of pneumothorax after the operations, and no infection complication. And what was interesting to find out was the myotomies and histology were all onto the junction and went onto the gastric sides. What about the physiology results? Less pressure was dropped 50% in the endoscopic group, a little bit better in the open group. But if we look at distensibility, we can see that both techniques achieved the same increase in distensibility. So the two operations were performing the same. But a very interesting point was the increase in distensibility. So we were relieving the outflow obstruction as soon as we were touching the circular fiber. Nothing happened with the longitudinal. So longitudinal fiber had nothing to do with the obstruction. And mostly this increase happened at the level of the gastroesophageal junction, as we would have expected. So we modified our approach to a tailored selective submucosal myotomy, which was tailored only to match the lower esophageal high pressure zone and extend a little bit above and beyond. In order to locate perfectly well the gastroesophageal junction and retroflexion, we had ink at the level of the cardia, and to be able to understand exactly our orientation when we were in the tunnel. And on the right side, you see this new selective approach that we are performing today. Again, just incising the circular fibers, as is shown here. You can use a different variety of instruments. We like to initiate the myotomy with a needle knife and then proceed with an IT knife, which has a protective ceramic tip. It's a rather safer device, or a triangular knife. This idea gave also another thought. Why not do an inverse submucosal myotomy? Why can't we do a gastroesophageal myotomy approaching the hiatus from the other way around? We had the opportunity to work with our storage industry to develop this new endoscopic platform, the Anubiscope, which is capable of giving a very stable support and to give you the opportunity to use these triangulation flexible instruments. And this is the way we approach the gastroesophageal junction in retroflexion. And you see that you can use conventional instruments that you would use in laparoscopy, a grasper and a hook. And on the right side, you have a very ugly picture, it's me taking it, in fact, of the myotomy at the end of the procedure. So another way of seeing things. There are a few open questions that we need to answer before this technique can be widely used in the clinical population. Can we treat any patients with achalasia with a POEM technique, what is the adequate length of the myotomy? Should we tailor to the less length? Should we assess patient symptoms and tailor it based on patient symptoms? For instance, long myotomy in patients that have chest pain. What are the long-term results? Should we worry about recurrence because of healing and scarring? Should we perform a bilateral myotomy or maybe a myomectomy? And what about GERD? Well, Dr. Inoue, with his beautiful work, was able to answer some of those questions. His results are absolutely outstanding. He achieved a very good drop in lower esophageal sphincter pressure and reduction of dysphagia. And he was so kind as to give him his series. He performed 87 POEM procedure till today, 25 of which on sigmoid type esophagus, and 5 after surgical failed myotomy. We thought about applying the concept of bilateral myotomy to lengthen the esophagus. And a perfect example for us was a disease that is extremely difficult to treat and has very bad results in terms of outcome, which is esophageal atresia. So what is the problem in atresia? It's long gap. The primary end-to-end anastomosis is the one that should be done because has a better outcome in terms of physiologic results, but it's difficult because the esophagus is short. Different kind of myotomies have been tried. The circular myotomies was deemed to outpouching and dilation, and we do know that the immobilization of the proximal stump has been associated with an increased morbidity. So what we've done, we modified the Livatidis technique in a bilateral myotomy, which would lengthen the esophagus only limited on the circular fibers. We access the stomach through a peg, and we perform a magnetic anastomosis with a manumosis technique that was originally described by Mike Harrison in Stanford. And this is what it looks like. So here you have a representation of the bilateral myotomy, very similar technique to what we've seen before. This is on the proximal esophageal stump. And we saw that the bilateral myotomy was capable of elongating the esophagus 1 centimeter for each 2 centimeters of myotomies. The model was created thoracoscopically. Here you see the division of the esophagus with a stapler. The pig esophagus has very little attachment, so as soon as you divide it, it will just spring back. There is no need to perform a real esophageal resection. And here you see the 2 endoscopes that are trying to touch each other, one from the stomach through the peg axis and one from the proximal stump. So you see the myotomy being performed. We tried to perform myotomy at slightly different levels because the way we are closing our entrance point is with endoscopic clips, and to have the myotomy at the same level would have created a lot of bulk of metal into the esophagus. So again, the same technique you have seen before. Advancing very gently. You can also use, of course, injection of methylene blue and saline in order to increase the space and improve the dissection. And again, you can see very well how the vascular supply is completely different in the mucosa and in the muscular layer. Here we are incising the muscular layer, and at this time you have to be extremely careful because we are working in the proximal esophagus, so the very, very gentle and careful dissection. Here we're using the triangle knife in order just to touch the circular fibers. And then the other myotomy is performed. You end up with an axis that is about 2 centimeters, so it can be a little bit tricky to close. The way to lift up the mucosa and to cut it can be done vertically or horizontally. We found now that an horizontal cut is much easier. So the second myotomy is now started and completed. So what we're going to do now is to close bilaterally the entrance point and to try to see if the 2 endoscopes can now touch as shown here. The next step would be to use the magnetic anastomosis, those two rings that were developed from the Murphy button originally, that are hollow inside and can apply different pressure along the esophageal wall. And you can see that as soon as they're close enough, they touch, and here is the anastomosis. They're supposed to create the anastomosis between just a few days, 3 to 4. And I would like to end my presentation showing you this. It's not a cup of champagne, but it's baby smooth muscular cells. And I think that endoscopy is the presence of the treatment of achalasia. I think this is going to be the future molecular engineering of cells to treat esophageal dysmotility, GERD, and one-out achalasia. We've been doing, in collaboration with Jay Pershrik at Stanford, this cellular study which aims at creating a tissue bank of cells cultured from the esophageal tunneling technique and esophageal muscles of patients and at the moment animals undergoing these procedures, to culture them and to modify them and reinject them in patients after having performed a myotomy in order to reestablish a normal esophagus. Thank you very much.